Good afternoon, my friends. The doctor is in the house. Welcome back to another episode of To Your Health with Dr. G. My name is Dr. Mark Gomez. I'm a board-certified internal medicine physician practicing in the western suburbs of Chicago. Welcome back, everybody, on this happy Wednesday. And I am so excited to talk about today's topic because this topic affects so many of us, whether it's your family member, a loved one, a friend, or even yourself. Today we're going to be talking about defeating diabetes. Yes. So what I want to do, of course, is welcome everybody back to the show. Those of us that have been listening to us and following us since the beginning, we thank you for following and paying attention and just really keeping this movement alive on health empowerment. For those of you that are new to us, each week I invite a group of guests, esteemed experts, and we talk about health topics. So today we're going to be talking about diabetes, and again, today's title is Defeating Diabetes. Again, my name is Dr. Mark Gomez. You can check me out at www.drmarkgomez.com. Follow me on Twitter, Instagram, and Facebook. My handle is @ToYourHealth, Dr. G. I want to thank our platinum level sponsor, Philips Eye Center. So again, today we're going to be talking about defeating diabetes. And let me hit you guys with a couple quick stats, because this is important. But before we hit those stats, I want to hit you guys with a quick disclaimer. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and/or treatment. Further details can be found at www.toyourhealthwithdrg.com/disclaimer. So again, welcome back, everybody. Today is our 15th show, so this is kind of a milestone of an idea that was created a long time ago. So I have to just praise and be blessed that we're here today on this milestone show. So before we get into talking and getting to meet our esteemed guests, I want to hit you guys with a couple quick stats on diabetes. This is taken straight from the American Diabetes Association on statistics. So, prevalence of diabetes. In 2015, 30.3 million Americans, or 9.4% of the population, had diabetes. The prevalence in seniors, those aged 65 and older, remains high at about 12 million seniors that are diagnosed and undiagnosed. There are approximately 1.5 million Americans are diagnosed with diabetes every year. And pre-diabetes, which we're going to get into a little bit later today, a lot of people may not be too familiar with that term. Pre-diabetes, in the year 2015, 84.1 million Americans aged 18 and older had pre-diabetes and having much higher risk for developing diabetes. And then deaths. Diabetes remains the 7th leading cause of death in the United States in 2015. So this is like really important because we are all touched by somebody that has diabetes. And when you guys get to meet our guests today, they're going to talk with passion, they're going to talk with purpose, they're going to talk about all the ways that are out there to hopefully help manage, decrease the burden, and allow us to live healthier and happy lives with diabetes. So without further ado, I want to introduce my guests. So I'm just excited to have this group here today. They are literally #fierce when it comes to diabetes, and really giving us a variety of perspectives on how best to defeat this condition. So my first guest, immediately to my right, is Dr. Susan Hudec. She's a board-certified endocrinologist with Elmhurst Clinic. You can check them out at www.eehealth.org. She's also a Loyola Strict School of Medicine graduate, so we had to connect. And those of you that have heard this show before, I'm a proud alum of Loyola Strict School of Medicine. So Dr. Hudec, welcome to the show.
Thank you so much for having me. I'm very glad to be here.
All right. Please tell us a little bit about yourself, like where you train. You can say Loyola as much as you want, but please tell us a little bit about where you trained, where you did your fellowship, and really kind of like just a typical day for you related to diabetes.
Okay. So, as you said, I graduated from Loyola Strict School of Medicine, and from there went to Georgetown University for my residency in internal medicine. And then I missed Loyola so much that I went back to Loyola for my fellowship in endocrinology. And from there have been practicing at Elmhurst Clinic for the last 6 years. We built a new endocrine program with Elmhurst Clinic there when I started, which has been great and grown significantly over the last couple of years. General endocrinology practice, I would say at least 60 to 70% of my patients are diabetics every single day. A typical day for me, a patient load would be somewhere between 20 to 30 patients on my busiest day. And yeah, at least 15 to 20 of those patients are going to be diabetics. So it's a lot of what I do every single day, and we are very excited about helping our patients do the best they can and really get those blood sugars to where they need to be.
Thank you very much for coming out today. I can't wait to get even more granular on things and talk about diabetes in even more detail. So thank you for coming on the show today. So thank you very much. My next guest, he and I connected almost 2 years ago, and maybe it's fate. I believe in a higher power out there, so maybe this is fate that my next guest and I connected. I've gotten to know him personally and professionally. He's a good friend of ours, good friend of the family. So we go out on double dates and everything. So again, it's just great, but he's just a great colleague, an expert in his craft. So I'm going to welcome to the show Dr. Michael Grassi. He's a board-certified ophthalmologist and retinal medicine expert. You can check him out at www.grassi.com. Dr. Grassi, welcome to the show.
Thank you very much for having me.
Hey, you bet, anytime. Well, Dr. Grassi, just tell us a little bit about your background, where you trained at, where you did your medical school, where you did your ophthalmology residency, where you did your fellowship in retinal medicine, and then how it kind of pertains, how's like a typical day for you in relation to diabetes?
So I went to medical school at Northwestern, and that was followed by an ophthalmology residency at the University of Iowa. And then following my residency, I did a fellowship in Retina, also at the University of Iowa. And I combined the fellowship. I stayed actually a little longer with a research fellowship as well. And so a typical week for me combines not only patient care and seeing patients with diabetic retinopathy and other retinal diseases, but also I run an NIH-funded laboratory at the University of Illinois at Chicago, and we're funded to study diabetic retinopathy in terms of one's genetic predisposition to developing it, and maybe later on we can talk a little bit more about the meaning and significance of that.
Excellent. Thank you, Dr. Grassi, for coming on to the show. And then my last guest, I am so excited to have her here. She and I connected many years ago, and we've done some volunteer stuff throughout the community over the years, and we just really gotten to know each other. She sees a ton of my patients. There's no doubt about that, but I knew when I was crafting the show on diabetes that I wanted to invite her onto the show and just really kind of get her take on everything. Somebody who's in it, in the trenches, so to speak, with patients and really trying to help them overcome and persevere in diabetes management. So I want to welcome to the show Celia Morelos. She's a BSN, RN, and certified diabetic educator with Edward Medical Group. Check them out, www.eehealth.org. Celia, thank you for coming out onto the show today.
Thank you so much for having me, and I am excited to come up on this show and really dismiss some of the myths with diabetes. I had my training at North Park University. While I was in nursing school, I worked at St. Mary of Nazareth in Chicago, and that's my growing points. My roots are there. I started to work in the metabolic unit there, and the role of the diabetes educator about 26 years ago was not what it is now. It was just starting. And from there, once I graduated from school and worked a little, I went to work at Lutheran General Hospital, doing diabetes education also in and outpatient, and have been at Edward Hospital now for 15 years, doing, again, diabetes education, running a lot of the outpatient clinics where I see nothing but diabetics. A normal day in my life is 10 to 14 diabetic patients in all realms of diabetes. And not only do I live it with my patients, I have diabetes. So for me, it's a passion to try to beat it, and I would gladly give up my job if we can find a cure.
It's, you speak with some passion, and it makes it personal when you're going through the condition yourself. So again, we know people that are touched by this. We are people that have diabetes. We are people that have family members that have diabetes or have succumbed to complications of diabetes. So this show today is really about how can we get better at this? How can we best defeat and take on the challenge out there of this diabetes epidemic? So what we do each week, now that you guys have met our guests, and I'm super excited, there's just the panel again, is #fierce. But now that we've met the panel, I want to kind of introduce you guys to the topic a little bit more. So each week we talk about what's called the chief complaint, and then we'll do something on the back end called the assessment and plan. So for those of you that are new to the program, we have a clinical question, kind of the question of the hour. And the chief complaint from a medical standpoint is when somebody comes in with their reason for seeing the physician at that time. So the chief complaint, aka the question of the hour today, is how do we best combat the rise of diabetes in this country? But let me give you a quick thing, just a quick couple notes. We're going to take a little step back because we're all very familiar with diabetes, but I don't assume that everybody knows what diabetes is. So I'm going to actually ask the first question to Dr. Hudec. Dr. Hudec, what is diabetes?
It's a good question, and I think misunderstood frequently. So diabetes mellitus basically is an issue where your blood sugar in your blood is too high. From a medical standpoint, the cutoff for us is a number of 126. So if you go and have your routine blood work drawn, you're fasting, you get your labs with your doctor at your physical every year, you want to have a blood sugar less than 100. If you have a blood sugar between 100 and 126, that would be pre-diabetes, which we'll talk about a little bit later. And if you have that blood sugar above 126, that's when we're really concerned about diabetes.
Wow. And I think about just the impact of it. I mean, again, people, so many things that we got going on in our lives, and certainly in this country when we see rising epidemics, not only cardiovascular disease is still a top killer in this country, cancer, we obviously are very faced with some of that reality, but diabetes, the problem is just getting worse. And the reality is that with the rising obesity epidemic, we're seeing more and more people that are getting diagnosed, but there's still so many people that are out there that don't know they have it because some people still do not go to the doctor. And as a primary care doctor, that's like my calling. It's like, I want you to come to the doctor. When I go out and I talk at different health fairs, I say, one of the first questions I ask is, raise your hand if you haven't seen your doctor in more than a year. And like literally every hand in the room goes up. And I go, no, you gotta put your hands down. We want you to see your doctor at least once a year for a physical. So you're driving home the point.
And especially, I think, because we're seeing it in younger patients. So I think that's really important. Everybody thinks, I'm in my 20s, I'm healthy, why do I need a physical? But we're seeing diabetes in 15-year-olds, 16-year-olds, in really young patients. So it's really important to get those screening tests.
Dr. Hudec, why don't you tell us a little bit about, you mentioned the fasting blood sugar as a test, but there are a couple other tests that are out there for screening. Can you just give us a little bit of breakdown on the 2-hour oral glucose tolerance test and then hemoglobin A1C?
Right, so 2 other tests to diagnose diabetes. I think the second most popular, or maybe arguably the most popular, is something we call a hemoglobin A1C level, which is a blood test that measures your blood sugar over the last 3 months. So it really gives us kind of an average of where things are, because a blood sugar by itself is just a point in time. It's just what it is at that moment, and it can change moment to moment. So an A1C under 6-ish is normal. 6 to 6.5 would be pre-diabetes, and anything over 6.5 would be diabetes. Now, lots of community health fairs sometimes have the ability to do an A1C, or it's frequently done sometimes in employee physicals, so there are other ways you can get an A1C done, but again, at that yearly physical is a good place to get that done. The 2-hour oral glucose tolerance test has somewhat gone out of favor, mostly because it's a hard test to do. The patient essentially gets kind of this orange glucose drink and then has their sugar checked again 2 hours later to see how they respond to the drink. It's still the standard of care in all pregnant patients, so we do it a lot in pregnancy, and anybody listening who's had a baby will remember doing this test. But less common, I would say, for just a routine diagnosis of diabetes.
Excellent. I want to ask the next question to Celia. Celia, do you see diabetes? I mean, diabetes affects us all. It doesn't matter on like ethnicity, background. But what are some of the populations that are more at risk for diabetes when you look at things?
So when we talk about populations, I usually say yes, people of color are about 3 times more apt to develop diabetes if they have sedentary lifestyles, if they're leading other chronic illnesses, hypertension, if they're usually cancer survivors or others, but definitely absolutely people of color. In the Pima Indians, almost 50% of the male population has diabetes due to, yes, diet and the sedentary lifestyles that we lead.
Wow. And again, diabetes, and along with a lot of other health conditions, does not discriminate. And again, this is why we talk about primary care and primary prevention. We want people to live active and healthy lifestyles, but that involves getting a medical assessment periodically. I always tell my patient, I go, I want to see, even if you're the healthiest of patients, I want to see you once a year. And we're going to check some labs, and we're going to get a baseline. And again, as I've mentioned many times on this show, you have to establish the fact that you're not dying before you can start living. And that involves getting that medical exam, and also the labs. And I always tell people, when you come in, it's one thing to get the medical exam done, a do-over by your doctor, but you have to go for the labs.
Yes.
That has to happen. On the flip side, if an employer, as Dr. Hudec mentioned, she's seen it a lot on the employer side. Employers are getting a little more crafty where they're doing wellness screens, and you're seeing some of these labs done. So you can actually hopefully try to identify somebody at that time based on an exam, if the employer provides for that, that's free of charge. So we really want to tell people to kind of have be on the lookout for diabetes. Let me ask the next question to Dr. Grassi. So when I was crafting the show, I knew I had to have you on because of what you do as an ophthalmologist and a retinal specialist. But a lot of lay people may not understand the importance of having an eye doctor as part of their medical team when you think about diabetes. So can you talk a little bit about maybe that barrier, why maybe sometimes there might be a barrier for people to, or I want to take it a step back, why don't you talk about just what's the role of the ophthalmologist and the retinal specialist in diabetes?
Well, it's an interesting point that you raise, and so on one hand, I'll share a statistic with you. So the statistic is diabetes through diabetic retinopathy is the #1 cause in this country of irreversible vision loss, meaning blindness in this country, 2018. So that's a alarming statistic on one hand, and the problem is on the other hand is it's completely asymptomatic until the end stages. And so if you use the analogy of your car, it's like breaking down on the Eisenhower and then the red light going on in the dashboard. That's a little too late, right? And so from a patient standpoint, they say, I'm doing fine. Why would I need to see an eye doctor?
My vision's good, yeah. I get it all the time.
Meanwhile, they can have perfectly fine vision, but the retina can be very diseased and just on the precipice of irreversible vision loss, because the retina, like the brain or spinal cord, is neural tissue. And like most things in life, sort of an ounce of prevention is worth a pound of cure. And so those annual dilated exams that we've talked about before are really critical in terms of being able to prevent that vision loss and be able to sort of going back to that car analogy, look under the hood before the car breaks down.
And I keep a sign in my exam rooms in my office where I've got a picture of two boys. They're holding balls. And the top picture is a kind of a shaded picture. It's kind of foggy, kind of gray. There's a little bit of black spots, not as sharp on the contrast of things. And then I have a bottom picture which you can see the boys in kind of like high-def 20/20 vision. And it says, get your eyes checked. Prevent diabetic retinopathy. And I always like to have that sign. That sign really hits home because for a lot of us, we're visual learners. And if you can kind of tell people exactly what you said, if you can say, hey, you may not have any symptoms at all, but I can guarantee you that if your blood sugar is high, there's some stuff going on. So you want to really try to drive home that urgency. Well, let me ask you just a repeat follow-up question. Do you see people at a certain, like when you talk about diabetic changes in the eye, do you see it more at a higher blood sugar level or a lower blood sugar level, or does it really even matter?
So, great question. The two major risk factors for diabetic retinopathy developing and then progressing to vision loss are first duration of diabetes, meaning the longer you have it, the more risk you're at of developing it. And then almost in a one-to-one level is glycemic level. So your A1C or your blood sugar, the higher that is on average, the more likely you are to develop vision loss from diabetic retinopathy. But the fact of the matter is, all individuals over time will go on to develop diabetic retinopathy. The key thing is that we can prevent these days vision loss in the vast majority of them just through routine care.
And think about like a lot of routine care, and as a primary care doctor, yes, I'm tasked to do a lot of things, certainly looking for conditions. You know, it's interesting, I want to ask this next question to Dr. Hudec. There's guidelines out there on how often to screen. I pretty much just screen everybody, and maybe I'm going maybe a little against the grain by the American Diabetes Association, which I think they say, you know, they a lot of some of the old guidelines say, like, don't look at somebody's weight, look at somebody's age. I just kind of universally screen. Is that a bad approach to kind of say, hey, you're a 22-year-old kid, I know you don't look too bad, but you're going to get an A1C anyways as part of your general metabolic panel?
Right. I don't think it's a bad way to go. I think we know 60% of Americans are overweight. That's a pretty general statistic. And so, you know, most of the population is at risk for diabetes, and given the strong genetic component in some families and ethnicities, I think it's fair to screen a large percentage of the population. Yeah.
Thank you very much. I want to ask Celia the next question. So, you know, the role of the clinical diabetes educator, I mean, is so important, and we talk a lot about, in anything in health, we talk about having a team. When it comes to diabetes, you can't underscore that fact even more, the fact that you need a multidisciplinary approach. Tell us a little bit more how you kind of help augment the medical treatment team with some of the things that you do. And then on the follow-up question, why don't some people take advantage of professionals like you in their general diabetes care?
So, thank you for asking that, because you're right. I think that one of the things that prevents a lot of physicians from referring their patients to a diabetes educator is lack of knowledge. Our roles aren't really well defined, and there aren't a lot of us either. And of course, how does that help the regular physician or the endocrinologist or any specialist that touches a diabetic? The fact that I have the time to sit down and talk to the patients and explain to them what truly diabetes is in their level. Because being a diabetic and seeing diabetics for so many years, I can actually say that there are as many diabetic regimens as there are diabetics. And I think that empowering the patients with knowledge of how to treat, not just treat, I should say, but how to live with diabetes, and continue to remind them how important it is for them to get annual checkups or visit their physician every 3 months, go to the dentist every 6 months. You know, just in general helps the regular physician, first of all, have the patients meet those guidelines from the ADA, which is to have a lower A1C or an A1C under 7. We no longer want 8s, we want under 7. Dr. Hudec is shaking her head because this is truly where we want the diabetic patients to be. And so I think that actually helps any provider to understand that. Plus, I have the time to overcome fears with patients, and there's been many days when we spend hours trying to get someone to give an insulin injection, and we know all the extra latest and greatest tools and meds that are out there that we can possibly recommend to those physicians. So I think, you know, going back to your question, why do they not take advantage? I just think that they don't know that we're there, that we exist, or that what truly is that we do.
Yeah, and you mentioned about not knowing that it exists. I mean, you can have a great idea, you can have a great resource, but if people don't know about it, well, you know, it's going to be a lost opportunity. And I think the role of my job as a primary care doctor, and I challenge people that are out there listening to the show, if you have diabetes or you're familiar with diabetes and your primary care doctor has not mentioned connecting with a certified diabetes educator, a clinical diabetes educator, then I implore you to make that connection. And if your healthcare provider doesn't have that resource, I'd ask them to find a local resource. Perhaps if they contact their local endocrinologist, they might have another resource as well too. But I want people out there to know that there are resources out there, and I want you to take advantage of them. You don't have to face diabetes alone. You know, diabetes doesn't mean a death sentence. And I think sometimes we have that in our minds, and or sometimes we even kind of passively accept it. If you say, oh, well, my grandma had diabetes, my mom had diabetes, so I'm pretty much resigned to the fact that I'm going to get diabetes. So, you know, so That's just part of my life. And you're like, whoa, you have a lot of choice in the matter. Would you echo that comment, Dr. Hudec?
I would agree, and I'm thinking of a patient of mine who has had that exact conversation with me. My dad had it, my grandma had it. What do I care? I'm not doing anything about it. And she's 18. But I think the point is that you can do better because you know the steps that went wrong when you look at those patients before you and say, well, this time I'm going to exercise more. I'm going to change my diet up front. And if the genetics are that that diabetes is going to happen whenever it happens in your lifetime, you know, medicine and the medications and the technology to treat diabetes has come so far. Just in the last 5 years I've been practicing, but in the last 10 or 20, that there are so many good ways we can treat diabetes and prevent those complications from happening.
Excellent, thank you. Let's talk a little bit more about some of the treatment. I want to kind of go into that a little bit. One of the biggest things that I get asked, certainly as a primary care doctor, when you mention somebody that they're diabetes, the first thing is like, oh no, I gotta get put on insulin, and it's just like this thing is like insulin's like bad. It's not bad. I mean, you got to treat your disease at the end of the day, but we get to face a lot of barriers. So I'm going to ask you another follow-up question, Dr. Hudec. Why are there barriers out there? I mean, you see it all the time, and people might say, oh, yes, my A1C is 10 and it's really high, but I think I'm going to do it now. I'm like really going to dedicate myself. And you're talking about insulin, but why is there such reservations to like try good medicine if they really need it because it can save their life?
Yeah. I think I see two main reasons for fear of insulin in our practice. The first is everyone has this picture of insulin as this old-fashioned glass vial with a huge syringe that they're going to have to inject into their belly, and that's not what insulin is. It's a really, really tiny needle you can hardly feel. Comes in a pen, you dial up the dose, you push the button. Super easy. You can have that pen in your purse, in your work drawer, anywhere. They don't need to be refrigerated for 28 days. So it's a lot easier than most patients think. And then I think the second reason sometimes is that frequently a doctor will have said to them, well, you can take these pills, but if you do a bad job, I'm putting you on insulin. Like a threat, like you failed if you go on insulin. A lot of patients will tell me, well, I feel like I failed because I need insulin. You didn't fail. I always tell patients you win when your blood sugars are normal and you're defeating diabetes and preventing the complication. Whatever medicine it takes to get you there, that's the goal. And insulin or any other kind of medicine is not that you failed.
Celia, as a diabetic educator, how do you go about teaching people about insulin?
So funny you asked that question. I just saw a patient of yours this morning who the same way he came in with an A1C of 13. And he said, well, the doctor wants me to inject insulin and I'm not going to go there because whoa, wait a minute. And so what you have to sit down and do is really, again, explain what is insulin. And the fact is that if we can't use it or can't produce it, we need it. And unfortunately, it has to be a form of an injection. And when it comes down to it, you have to find out what their fears are. A lot of them is they're afraid of the needle. And when I pull the cap off that pen needle, the nano is so small that, oh, you can't even see it. I said, and you can't even feel it. And you just go about what you can to get whatever fear they have. I hear a lot, well, so-and-so was injecting insulin and they lost their legs. Or so-and-so was injecting insulin and they went blind. Or all these complications, and then I ask, but was their glucose levels controlled? And at the end, it's not about being on insulin or an injection or an insulin pump. It's about, are you on the right dose? Are you doing that? And then I explain it a different way and say, there are 3 things that you have to do to control and to live with diabetes safely. A third is diet. The other third is activity, and the last third is medication. So we don't rely only on insulin, and we talk about that. Sometimes it takes me a little bit longer depending on the patient, and sometimes it's, okay, let's not do it. Let's have you make these changes and come back in 2 weeks. Sometimes I see them every week until they're able to say, I can do this on my own.
I want people out there to know that, yes, you can conquer diabetes. I love what Dr. Hudec said. When you're winning at diabetes, that means your blood sugars are lower. and nice and simple. So the hashtag winning, we're going to start that up again, like hashtag winning. But yes, defeating diabetes, that's what it's all about. It's about using these resources, dispelling some myths, and looking at opportunities for success. I want to ask the next question to Dr. Grassi. We talked about a little bit of the diabetes being, a very leading cause. You say it's the leading cause of preventable blindness?
So the number one cause of irreversible vision loss in working age adults in the U.S.
What are are there other things that you might see somebody, so say somebody's got some issues and they have some pretty progressive eye disease, ocular disease from diabetes. What kind of symptoms might that person complain of when they come into your office?
Well, again, I want to emphasize the point that up until the late stages, the patient can be completely asymptomatic and have 20/20 vision, and that's why often it's so unfortunate when the patient shows up in my office at that point. Because through a combination primarily of all the factors that were just raised in terms of keeping the hemoglobin A1C at 7 or less and weight loss and exercise, these things will help getting it to the retinopathy to that stage. When a patient is symptomatic, it's because there's actual pathology in the retina, and what that means is the disease causes leakage from the normal vessels. The retina is like any other tissue in your body, like your skin. It has blood vessels that bring in oxygen and nutrients and remove carbon dioxide and waste products. And over time, the diabetes injures the smallest blood vessels that supply the cells of the retina. And over time, those blood vessels leak fluid into the retina. And I sort of think of it like after a storm in a field, there are little puddles there. And if you leave, if those puddles stay for a while, the grass in those areas is what? Not quite as good or strong or healthy as the grass in other areas. And so that's the most common problem we see. It's called diabetic macular edema. And it causes, like that picture you were describing, blurry spots or just blurriness in the center part of the vision. And the center part of the vision is what we need, right? To read, to drive, to work. And again, there are things that we can do to help that, but the best medicine for that is prevention.
I want to ask you a final question, because I'll get this asked to me sometimes. A patient may come back in to see me, and they say, hey, I saw my eye care professional, I saw my ophthalmologist, my retinal specialist, and they say, they're recommending laser therapy. And people will ask me, they say, Dr. G, should I get this? And of course my answer is like, yeah, if you've got significant retinal disease from your diabetes, you've got to treat it. I mean, there it is. I mean, do you want to lose more vision if they're at that point where they're very symptomatic? But why don't you just tell us a quick kind of brief kind of explanation of what is kind of photocoagulation therapy? When you have to kind of use that resource to help people out? Can you give us a little bit of just kind of a primer on that?
So up until 10 years ago, the standard of care for treating this swelling in the retina was focal laser treatment, in which we would use a laser to thermally seal these leaky areas in the eye. And the reason we would do that is it was demonstrated to prevent further vision loss. So that's not such a great treatment, right? When you go see a doctor, you want to get back to the way you were. You don't want to not get any worse. And so that was the standard of care up until a new medicine was developed that more elegantly targets the factors that cause this leakiness in the eye. And so as we were talking about, the capillaries in the eye, these small blood vessels that nourish the cells in the retina, become injured. And the cells send out an SOS signal, sort of no different than a boat out at sea with sailors might send out an SOS signal if it was running out of food and water. And the body responds to that in several ways. So it turns out that scientists were able to figure out what that molecule, what that SOS signal was, And so the medicine we inject into the eye blocks that SOS signal. Now, it doesn't make the diabetes go away, but it makes the leakage better, and it helps the body sort of reabsorb that fluid. And so, the main treatment now is injecting medicine in the eye. We use laser treatment occasionally to complement that, but because the injections not only stabilize things, but in over close to 50% of patients actually improve vision, it's become sort of the new go-to.
Excellent. Well, thank you for breaking down that concept. I want to take a brief moment to acknowledge our sponsors today. Then we're going to get into some fun stuff. If this is fun already, though, don't get me wrong. I want to just thank our sponsor today, Philips Eye Center. The physicians at Philips Eye Center are committed to providing the highest quality of comprehensive eye care to our patients. They offer a wide range of ophthalmic services, including laser and surgical treatments for many diseases of the eye. Just a few of their services include surgical and medical treatment for glaucoma by our glaucoma specialist, cataract surgery, treatment of diabetic complications including laser, treatment of macular degeneration, and treatment of dry eye syndrome. Ultimately, their goal is to diagnose, educate, and treat their patients in a respectful manner, surpassing their expectations. Philips Eye Center has office locations in Naperville and Bolingbrook, Illinois. For more information, call 630-378-4799. So thank you very much, Philips Eye Center. So I want to ask this next question to Dr. Hudec, and I want to kind of just break it down a little bit, even a little bit more. Why don't we just give me some stats, maybe on like what, why don't we take it a step back? What is type 1 diabetes versus type 2 diabetes? And maybe you can give us a little stats of what's more common.
Fair enough. Very good question. Kind of back off more of the basics of diabetes here. So type 1 diabetes is the minority of what we see. So about 10 to 15% of diabetics are type 1s. Type 1 diabetes is complete destruction of the pancreas. So the pancreas is completely non-functional. For most commonly an autoimmune disease, but can also, essentially you could have type 1 diabetes if you had surgical removal of the pancreas for some reason in patients, or if they had chronic damage to the pancreas from recurrent pancreatitis. Occasionally we'll see that. Patients in type 1 diabetes have to be treated with insulin. There's no other option. They have to be on full insulin replacement, which is aggressive insulin therapy. And typically those patients will get an insulin pump or some other technology to help them manage their diabetes. The advances in technology in diabetes is huge.
Yeah.
And maybe I'll touch on that in a moment. But type 2 diabetes is kind of the majority of what we see, 85% of the diabetics. Type 2 diabetes progresses over time. So it's a more slowly progressive disease. And essentially primary there you see insulin resistance as the cause. So your cells, your body no longer responds to insulin appropriately. As a result, your pancreas, which is an organ in your stomach, in your abdomen, starts making more and more insulin to try and overcome that insulin resistance. But eventually the cells in the pancreas can't keep up. Once the cells in the pancreas have been destroyed, at about 50% is when we can start to see type 2 diabetes. Okay, and in those patients, initially they can be treated with medication. Potentially right away at the beginning, they can be treated just with diet and exercise to try and cut down that insulin resistance, lose weight, try and help their pancreas be more effective. But a lot of patients with type 2 diabetes, because it is progressive, do progress to insulin therapy. So I don't want you to think just because I have type 2 I don't need insulin. You still very well may need insulin. And again, that's not a failure. It's just that by the time we diagnose the diabetes, your pancreas is more than 50% damaged. And more damage over time just means that you don't make that vital hormone that you need. And everyone needs insulin.
Yeah, I always use an analogy to my patients. I say the horse has left the barn and we need to go find that horse. The first thing you got to find the horse, and you got to catch it and then reel it back in. So sometimes you are behind a little bit on the disease burden. You have a disease burden that's outpacing your ability to start treating it, and so you have to kind of be more aggressive. Let me ask you a follow-up question. Why do you think, and I might be guilty of this myself, because I might see somebody with an A1C of 7.9 or 7.5, and I may not titrate a little bit, but why do we see some barriers maybe on some physicians that may not be as aggressive as we ought to be? If we're shooting for a target of less than 7, what are some of the barriers you see with that one?
So I think there are a lot of barriers to getting under 7. Sometimes it's that the patient saying, well, I'm going to do the diet. I'm going to go home and clean out my cabinets, and I'm not going to eat that anymore. I'm not going out for pizza, doctor. I promise. And fair enough, I think it's important to give the patient a trial to really work on those things. But, typically I'll make a deal with my patients. Like, all right, you've got 2 months. Show me what we can do. See the diabetic educator. Talk to them about it because they can really partner in this with you. But then if it's not better, we have to do medication. And I think, or let's start a medicine. We can always take it away if you do really great with the diet and exercise. So, there's that piece of it, which is a good thing. Some of the drugs do have side effects, and it can be expensive, and I understand it's important to find the right drug for the right patient. And then there's always the risk of hypoglycemia, which is a low blood sugar. So some of the drugs we use can drop the sugar too low, and it's sometimes in patients, despite our best efforts, 7.5 is where we get them without making them go too low, too high. But I think it really is important to aim for under 7, to try and get the patient there as best we can.
Excellent. I think some of the things the resources out there, and we want to just use them so much. You mentioned some of the tech that's out there. We also mentioned a little bit earlier that the needles are as thin as a strand of hair and as long as the tip of a pencil. We're trying to break down a lot of barriers. Celia, why don't you tell us a little bit about some of the tech that's out there? These continuous glucose monitors, things like that. What's out there on the market?
The biggest backdraw that you can get from patients when I say we have to monitor your glucose levels, we need absolutely some logs. And in fact, it's been years that I've asked patients to stop bringing logs because they'd be sitting in the waiting area writing it down or making up stories. Their A1Cs never matched the readings that they brought in. And so the big thing with technology is apps. There's a lot of apps now, and people, believe it or not, love it, where they can actually log their glucose levels, where they can log their activity, where they can get advice if they're on multiple insulin injections. They can actually get advice through these apps as to how, of course, we predetermine their insulin to carb ratio correction factors and all of that, and program it into these apps, and they can get all that. So that's easy, and most of them are free or very cheap. Insulin pens have come a long way. I think it's very rare that I teach vial and syringe these days to patients. So we have insulin pens for everything. We have new insulins that are now, dosed, or there's also obviously the almighty, I don't want to stick my fingers, and can I now not stick my fingers? And yes, glucose sensors are by far the biggest technology advancement that we've had in diabetes treatment, because they're not that expensive. We are getting insurance companies now to actually follow through and pay for or cover some of these glucose sensors, not just for type 1s, but for any diabetic that actually needs it. At the Edward Diabetes Center, we have done research with continuous glucose sensors, and believe it or not, only did it on type 2s, only did it on patients that were seen with primary care physicians and not on insulin, because we wanted these results to prove, not just to the patient themselves, their physician, but also the insurance companies. Medicare and Medicaid are by far our biggest stoppers when it comes to technology and maybe recent medications. So there is now the Libre Personal 10-day wear, waterproof, no finger sticks. The Dexcom G6, again, 10-day wear, waterproof, no finger sticks. I can tell you that I always would say to my patients, you know what, I sit on that other side of the table. I do test my glucose levels 4 times a day, and I hate it. I hate every minute of it. But now, and I would say, yeah, glucose sensors are okay. And now that I do wear a G6, it's so easy to get used to not testing. And I have that app right on my phone or my iWatch, and when I want to show them, I show them. When I go in to see my physician, I simply show them my app, and all readings are there. So those are by far the biggest advancements right now, besides insulin pumps.
Thank you very much, and I just love just the passion that you talk with, and these opportunities, these resources are out there for people, and for the tech savvy people, that patient that's very engaged and wants to truly defeat diabetes. And technology is evolving faster than we are evolving as humans, and so it's only a matter of time where we just have all this new tech, but you want to be able to use it, and hopefully that some of this new tech is more widely available. I want to just mention a couple things here. From my end as a primary care doctor, when I see my diabetic patients, we talk about the multidisciplinary approach. Yes, work with the diabetic educator, see the endocrinologist, see the ophthalmologist and retinal specialist. I tell them a couple things too. I say, I want you to exercise more, but you have to make sure somebody's able to even exercise in the first place. But a lot of the recommendations are out there that talk about aerobic activity, at least 150 minutes per week. At moderate intensity, or vigorous activity at 75 minutes per week. Sometimes that's not doable, but I just say just move. If you just move, and I tell people with tech, I say, all right, get 5,000 steps. You got a Fitbit or you got an iWatch, Apple Watch. So like just move. Just go for a walk with your family. Just do something. And I'm kind of the big believer, like any little bit counts. What's your thoughts on that, Dr. Hudec?
No, I agree. I mean, we see a lot of patients who can't do that cardiac, exercise because they're not ready either. Medically they're not ready. And I say, park your car at the end of the parking lot, right? So you can walk all the way into Target or the grocery store, Or if they're having trouble walking, walk with the cart so that you can walk a few extra laps in the store and try and get the exercise in. I think absolutely starting small and just getting it in wherever you can is important. And I'm sure Celia can speak to that too.
Yeah,
Yeah,
absolutely, that is exactly what I say. The goal is 30 minutes, and I would say that's the goal. But it's been 50 years and you haven't gotten up from that chair. So maybe all you can start doing is for 10 minutes, swing your legs while you're sitting down, move your torso. I do the same thing. Get up to the bathroom every half hour. Or if for nothing else, just go get a drink of water. Don't just sit for long periods of time, and any little bit helps. So besides using the cart, now when you're done using it, return it to the corral, or God forbid the grocery store, right? But so do more. If all you do is walk around your dining room table 4, 5 times, 3 times a day, that's already more than what you used to.
Excellent. I want to get into a little bit of myth versus fact, and we've done this on a couple of shows already, and I think when it comes to diabetes, it's super important. We got to dispel some. We're talking about defeating diabetes, you got to break down some barriers. So I got a section that I call Diabetes Myth versus Fact. And so my first question is going to be to Dr. Grassi. Here we go. You either answer myth or fact, my friend. And if you want to expand a little bit on it, you go right ahead. All right, first statement.
Can I get a lifeline?
You can get a lifeline. We have 2 experts here with Dr. Hudec and Celia, in case you don't know the answer. But I know you're going to do just fine. So here's the first question. I shouldn't say question. Here's the first statement. Diabetes myth versus fact. Here we go. Diabetes is not a serious disease.
I'm going to go with myth.
All right. I agree. Tell us a little bit more if you want to explain a little bit more on why it's a myth.
Well, I can speak most knowledgeably from my own vantage, and that is all of the potential avoidable vision loss that we see in this country. And so, again, I think it's powerful to look at what people and patients themselves say, and that is vision loss, blindness is the #1 feared disability. And diabetes is the #1 cause of that in this country. And so I can't re-emphasize the importance of what was just discussed in terms of the value of keeping that hemoglobin A1C as best as one can at or around 7, because it really pays off. Because, for instance, I have patients who've had diabetes 40, 50 years and have very minimal to no retinopathy because they're religious about their sugar.
Excellent. Thank you. Next statement to Dr. Hudec. Here we go. People with type 2 diabetes can't participate in sports or exercise.
Myth, largely a myth.
Please explain a little bit more.
Absolutely. Any diabetic can be largely active in exercise or sports. Type 2 and type 1 diabetics. For type 2 diabetics, exercise helps decrease their blood sugar, helps them lose weight. potentially, get them off some of their medicines. And patients with type 1, it's great to stay active, with pumps and continuous glucose monitors. That can be very safe. I had a patient do a triathlon, an Ironman, and it was very impressive. They can do great things.
Thank you. Next statement for Celia. All right, here we go. Prediabetes is usually not that serious.
Myth, 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 myth. So prediabetes, when I try to explain to patients what that is, and that means I don't have diabetes, right? Because pre means before I get it. And it's like, well, no, not really. If you either have normal glucose levels or you don't. You have normal pancreatic function or you don't. So the way I explain it is prediabetes is usually before you need medications. And we want to keep you in the prediabetes state because that's what's going to prevent the complication of diabetes. And diabetes is progressive. So if we don't keep those glucose levels at that A1C of less than 7, I can assure you that in a few months or a few years, you're going to have complications.
Thank you. Next statement for Dr. Hudec. Patients with diabetes should avoid restaurants.
Myth. Certainly diabetics can go anywhere and eat anywhere that anyone else can. They just want to, pay attention to what they're ordering and make sure to pick some healthy options.
Thank you. Yeah, I'm like these are we're teeing it up for you guys, but these are some of the things that I hear all the time. So when we're coming up with this myth versus fact, it's sometimes the things are you just astounded sometimes at the things that you hear. All right, next one for Dr. Grassi. All right, here we go. Patients with diabetes have very little control over the development of complications.
Myth.
All right.
As we were talking.
Correct, yeah, we spent plenty of time with that one. All right, next one for Celia. Here we go. Only people who have a family history of diabetes need to be tested for diabetes.
Myth. You heard Dr. Hudec say that earlier, and if it was up to me, I would have, that should be a part of their annual and every 6-month checkup, because especially if you belong to those races or those people of color that are more susceptible to developing diabetes, you want to make sure that you test so everyone can get diabetes.
Thank you, and I'll have the last one for Dr. Hudec. Here we go. Last statement, myth versus fact, diabetes style. All right, here we go. Fruit is a healthy food. Therefore, it is okay to eat as much fruit as you want.
Unfortunately, myth. Some fruits are much healthier than other fruits, as it turns out. The amount of sugar in fruit can be significant, particularly bananas are a particularly bad one, watermelon. We always tell patients, stick to the berries. That's a good pick. Strawberries, blueberries, raspberries. Apples tend to be better than other choices, and oranges not terrible. So, but some fruits are probably not so good.
Thank you. All right, well, we got about 5 minutes left, guys, so this has just been a great discussion. So what I want to do is, at the beginning of the show, we introduced the concept of the chief complaint. Now we're going to do what's called the assessment and plan, and for those familiar with our show, they know what it is by now. They should, because I've been talking about it every week on this show. But for those that are new to the show, the assessment plan is when somebody comes in and sees us in a clinical setting, we kind of wrap things up, we kind of give them their diagnosis, we give them their treatment plan, and hopefully a follow-up, which is the most important thing when it comes to diabetes. You have to follow up with your healthcare team. So what I want to do is I want to start out with Celia, and I want to ask Celia, just kind of give us a couple take-home points. Like, for people that are out there listening, they either have diabetes, or they have family members that have diabetes, or they know people that have succumbed to complications of diabetes. What are some take-home points on how we can defeat diabetes?
So the 3 things that I have always preached are eat healthier. Eat heart healthy. There is no such thing as a diabetes diet or a diabetic diet. Just eat heart healthy, low fat, low sugar. There's no sugar free because carbohydrates will turn into glucose. And then the second one is move your body through space at least a few minutes every day. And the third one is visit your physicians and get tested.
Excellent. Thank you. Dr. Grassi, a couple take-home points for defeating diabetes, please.
Well, the key things, I'm going to sound like a little bit of a broken record coming back to these points, but they are that diabetic retinopathy is typically asymptomatic until the late stages. And so you can have very severe disease and be asymptomatic. And that emphasizes the second point, which is the value of the annual dilated exam. That somebody needs to dilate the eyes and look at the retina and examine it at least once a year if you have diabetes. Only 60% of diabetic patients in this country right now have regular routine annual exams. And then the final point is that effort, when, again, it's easier said than done. It's easy for us to sit around the table and say hemoglobin A1C of 7, but that effort that goes into achieving that is really worth it and really pays off in terms of one's vision and
Well said. Dr. Hudec, a couple take-home points on defeating diabetes.
Defeating diabetes. We like to talk a lot about the ABCs of diabetes, so getting that A1C like under 7, like we've all talked about, getting your blood pressure under control, watching the cholesterol, getting that eye exam, and then watching those feet every year. So I think those are really important points in addition to everything else we said here today.
Thank you very much. And my kind of take-home message is this. You know, we're all busy, we're all going through life. Life's got some ups and downs, some bumps in the road. But when we come face to face with medical conditions, it really is a deciding and a defining moment in how we're going to persevere. And we want to always instill that message of courage and hope and faith that things will get better. You surround yourself with the right team. You surround yourself with a multidisciplinary team when it comes to diabetes. I guarantee you, if you do that, you will have success and finally defeat diabetes. So I want to thank my guests today, of course. We got Dr. Susan Hudec, board certified endocrinologist at Elmhurst Clinic. Check her out, www.eehealth.org. We got Dr. Michael Grassi, board certified ophthalmologist and retinal medicine expert. Check him out, www.grassiretina.com. And we have Celia Morelos, who is an amazing person, my good friend, diabetic educator with Ever Medical Group. Check her out, www.eehealth.org. I want to thank my platinum level sponsor, Phillips Eye Center. You know me, it's Dr. G. Check me out on my website, www.drmarkgomez.com. Check me out on Facebook, Twitter, and Instagram at To Your Health with Dr. G. Lastly, I want you guys to have a great day. And next week we're going to be talking about fostering healthy work relationships. Take care, everybody, and peace out.